Hello everyone, it is Gabby here, just jumping in at the beginning of this recording as I forgot to press record on the intro slides of our event, Classic Me. First one back, so I'm still finding my feet. But this event is How to Survive MD2, an event by Halad to Health in partnership with Outlook Rural Health Club as part of our MD2 revision sessions. So before we jump into the session, I would like to acknowledge the traditional and rightful owners of the land in which everyone is on. For myself, that is the Wiradjuri land. I'd like to pay my respect to the elders past, present and emerging, as well as acknowledge that the land in which I am on always was and always will be Aboriginal land. So during this event, Karim is the host alongside myself. So Karim is a third year UniMelb student this year at the Austin, and he is GAMSAT Section 3 lead as well as the MD2 lead for the revision sessions this year at Halad. Myself, I am GAMSAT Section 1 and 2 lead at Halad as well as the academics coordinator for these revision sessions, and I am an MD3 this year at UniMelb, placed in Cobram as part of the extended rural cohort program. So during this session, we provide you with a little bit of an insight as to what to expect in MD2, our advice, stuff we wish we knew before starting MD2. So I hope you find this event useful and it helps you get prepped for a big year ahead. Enjoy.
Thank you,
Now
Calista, for reminding us.
Yes, thank you very much. Does that say recording now?
Yeah.
Cool. Lovely. Thank you for that. So yes, let's jump in. Feel free to ask us any questions in the chat or unmute if you're brave. Okay, Karim, did you want to kick it off?
Yep, sounds good. So thank you everybody for joining along. It's really exciting to have you back. We hope that this information session is the much needed information session that we didn't get last year. But hopefully we're going to break down the structure of the year and just tell you guys about, how to survive an MD2 essentially. So let's first of all talk about the structure of MD2. And I also just want to say, if you guys want to interrupt with any questions at all, please feel free to do so. So just in terms of the breakdown of the year, I'm sure you guys will probably be somewhat familiar with this by now, but your year is broken up into 4 8-week blocks. So you've got foundations, general medicine, surgery, and ambulatory/ED. I want to preface by saying that a lot of different hospitals run things in slightly different ways. So we'll talk a lot more about that later. But in terms of things that are fairly similar across the board, the different subjects that you guys will have. So, everyone will have professional practice. Most of you will have clinical skills tutes. So these tutes are typically run by clinicians. So for me, for example, they were run by registrars, and we would often have like bedside tutes. So they'd actually take us to a patient and be like, okay, let's do a hand examination today. Let's do a respiratory examination. Let's take a history about chest pain or whatever it might be, what's brought you into hospital. And they're really fantastic tutes. But once again, it's different across each hospital. And yes, I'm at the Austin, and Gabby's in Shepparton, so she'll talk about her experience as well. There's also lab-based tutes, so procedural skills where you guys will learn to do things like putting in a catheter, sensitive examinations, venu puncture, cannulations, that sort of thing. Peer tutes. So at some point, you guys will get some sort of MD3 or MD4s that it will offer to teach you guys in small groups. I highly recommend trying to stick with those for the year. I know, for example, my group, we had a set of tutors that we saw for pretty much the entire year, and that was really fantastic. So I highly recommend trying to stick to those because they're very much a little bit harder to stick with in MD2, I feel, compared to MD1, but I recommend trying to stick with them. And then very hospital dependent, but you'll have specific surgical ED and gen med tutes. So for example, during my surgical rotation, we had a tute about, the acute abdomen. And so we talked about, what happens when a patient comes in complaining of stomach pain or abdominal pain. So that was very specific to surgical, and that was very specific to the Austin. Okay, so what can you actually get on your timetable? So what will your timetable look like? So attendance will be compulsory for some clinical schools and somewhat suggested for others. So I know at the Austin, for example, they're very lax about whether or not you have to attend everything. Whereas in some other clinical schools, they are very like, you have to have written notice to miss anything and that sort of stuff. So it's a bit of a luck of the draw there. But, there's a general understanding that you should try to go to all of your clinical placements. Some clinical schools provide extra lectures at their discretion. So, for example, once again, speaking of my Austin experience, we had lectures specifically on infectious diseases during our general med, gen med rotation, and they were really fun. But like no other, not well, to my knowledge, not many other clinical sites had them. So that might be in your timetable as well. So what can you be assigned to? So you guys will start seeing this come up soon, but you'll be assigned to different ward rounds and different teams, depending on the rotation that you're on. So in foundation, it moves around a little bit. You'll be on a gen med team, on an ambulatory placement in which you're just with that entire ED. You're not generally with like a specific team. And surge, you might be on neurosurge or cardiothoracics or whatever it might be. You'll be assigned some theater time. You'll be assigned, at the Austin, we have an anesthetics week. Other hospitals might have something different. So yeah, very wide range in terms of what you can have on your timetable.
Yeah, and every clinical school does it very differently. In Shepparton, our timetable was even filled with lectures as well, like the recorded lectures, giving us a suggested workflow of those as well. So our timetable looked very full, whereas other clinical schools, they didn't really have a timetable. So it is very varied. I would just try to find someone who is an MD3 at your clinical site if you're feeling lost about the timetable and things like that, and get advice from them. The good thing is, though, the foundation block that you have at the beginning of the year is just time for you to figure it all out and settle into your clinical site as well.
And yep, just once again, a note on the timetable, essentially, as Gabby said. So different hospitals will do different things. Like, for example, anesthetics week at the Austin, I never got any ICU placement. Some hospitals will do that. You've also got like trauma hospitals, like RCH is a big trauma center. So you guys will get a lot more training in terms of like trauma things. I didn't really get any trauma things. Like we had a somewhat kind of like a trauma team that we we joined. Gabby got to see a lot of trauma at Shepparton. Once again, Austin, I didn't. Yeah, so your experience will be very different to your friends, and we'll talk about that a bit more later.
Yeah, and COVID also has impacted experiences, obviously, especially surge, because there's little to no elective procedures happening. So if you do get the opportunity, really try to jump into these things. I was very hesitant because I hated surge from day dot. So it was very hard for me to muster up the motivation to go into theatres. And if you feel like that, I just encourage you to try your best to go to these opportunities, because we are very privileged to be able to have any of these opportunities, especially considering the current climate that we're living in. And you will learn something, even if you're not going to become a surgeon. If you don't need to know about this like random artery that the surgeon is like trying to hassle you about, it doesn't matter. You'll learn different things. You'll learn about how the different team members work in an environment like that. You'll learn things about sterility. You'll learn things about pre-op and post-op care, which I think is important for all specialties as well. So just try to jump into these situations. And if you miss out, don't stress. You will make it up either in MD3 or MD4. The clinical schools are really trying to make sure that MD4 year is a bit of a catch up for us pandemic med students. So hopefully that'll be good for us.
All right. And then another note. So I'm sure you guys might have had something about this already in your orientation days, but Canvas versus MD Connect, bit of a debate, bit of a hot debate at the moment. I reckon we were lucky enough to use MD Connect last year, because I actually found MD Connect to be really well organized. So have a look into it. MD Connect is very well structured in terms of like the lectures you need to watch in each like rotation. But I think they're trying to encourage us to use Canvas this year, and I think they're doing their best to like make it a little bit well structured in terms of like where you find your information for lectures and stuff. But on a side note, and this is entirely my experience, but I know that a lot of other people did something very similar. A lot of people didn't watch all of the lectures that they gave us last year, because you can find general information about all the things you need to know on other platforms, like for example, AMBOSS, therapeutic guidelines, past medicine, and other helpful resources, which we'll talk about later. So yeah, I definitely have like a lot of different things in your toolkit in terms of what you utilize for your learning. I think I might have had a question.
Yeah, just asking about those subscription services, AMBOSS, ETG, and Past Medicine, which ones are Australian? ETG is Australian and is used in all of the hospitals. Don't worry about paying for that. You can get that through, I think you can get it through Canvas, but you can absolutely get it through your hospital. But both AMBOSS and Past Med are UK based.
Yeah. Also, ETG you can get through UniMelb, because you can use Open Athens, which is like all sort of learning institutions. Yeah, AMBOSS is I think US, PassMed I think is UK, but don't like stress too much about guidelines yet, because a lot of what you'll be assessed on is very general knowledge and it's not specific to Australian guidelines. That's more like an MD4 thing.
Yeah, MD2 is all about learning how to detect conditions and diagnose conditions. So you want to know about like the definition of a specific condition, how to diagnose it. So the diagnostic criteria, different clinical features, different complications, the epidemiology, things like that, all of which are really brilliantly outlined on AMBOSS. So that's why that is such a great service. And it doesn't matter if, the antibiotics that they prescribe for a certain condition is different to what we do in Australia, because we don't have to know. Actually, I think we might now in MD3 have to know that, but that will come with time and practice anyway. So just focus on the big picture ideas with that stuff.
All right, I think this slide is super important. So definitely feel free to take a screenshot of this. But essentially, in terms of the content that you guys need to know for MD2, and this is sort of what Gabby was talking about, each placement has a list of core presentations that you need to know. So the main focus for MD2 is like the presentations, not so much the conditions, but you need to know the presentations and then the common differentials for each presentation. So you still need to know the conditions, but like say, for chest pain, like you really need to know like acute coronary syndrome and like pulmonary embolism, like, the really key differentials. And so those ones you need to know quite well. But each placement will have its own sort of set of core presentations, which you can find on the PCP2 subject guide. I highly recommend looking at that. It's got the full list of presentations on there. Also in there, you'll find the core drug list for the entire MD program. It's a huge list. There's so many medications on there. There's so many classes on there. Not very heavily tested in MD2, but it's sort of an opportunity to start familiarizing yourself with all of those drugs, because they'll come up again and again. So all the ones you learned in MD1, plus so many extras that you'll need to know about across the different specialties. You'll also have some radiology lectures. I really highly recommend looking at those, because it's the only way you sort of start to improve your radiology knowledge, because otherwise you don't get any other teaching on it. It's purely through the lectures. And clinicians expect you to be able to interpret like radiology pretty regularly.
Just on that, I did not watch the radiology lectures until the last 4 weeks, when Karim said, Gabby, you need to watch these lectures. They're very good. And I really regret it. I think it would have helped my learning throughout the entire year if I really just forced myself to watch the radiology lectures. The issue that I had with them was that they were quite long and they were live and scheduled at really random times, but you can just watch the recordings. So I definitely recommend integrating that earlier. Do as I say, not as I do, because I was really slack on that front. And it bit me in the bum at exam time for sure.
Same with Path. highly recommend staying up to date with that as well. They will test it. And it's only high yield path, like it's super, super high yield. It's nowhere near as detailed as MD1. Just the stuff that they actually really want you to know. So like, for example, like prostate cancer, like pathology for that is very important. So, that's what you'll get the lectures on. You'll also have something called clinical colloquia. I really like these. All of your MD assessments are essentially based on these concepts. And it's a very high yield skill. So clinical colloquia will be something like, a young man with chest pain, or gynecological, well, not really gynecological, but like say abdominal pain in an elderly patient, or like diarrhea in a young patient, something like that. But essentially the way you're assessed at the end of the year especially is based a lot on these clinical colloquia. So I recommend watching them.
Again, they're one of those lectures that I felt hesitant to watch because they are very lengthy, like about an hour and a
Like
half.
2 hours.
Yeah, 2 hours. And they can go on for quite a while because it's live and people are asking questions or answering questions and things like that. But I definitely recommend either coming to them live and engaging with them if you can, as much as you can, or watching the recording, or even just reading the lecture slides and basing your study off of the presentation and the conditions that they have listed, because they sort of do all your work for you, those clinical colloquia. So definitely don't miss out on those ones.
And finally, I just really wanted to mention clinical pharmacology. Yeah, we'll talk about MPC later. Actually, we can talk about it now. So in terms of clinical pharmacology, they don't really teach it. Like they don't have specific lectures for it. So say, for example, like you guys would have had lectures last year about antibiotics, about lipid lowering medications, about antihypertensives, that sort of stuff. It's sporadic and rare if they have those lectures. I can't really recall them. But what they do have a lot more of is these things called the MPC modules. So it's the National Prescribing Curriculum modules, and they're free to do online through the university, but the clinical schools won't necessarily tell you to do them. They're in the subject guide. Once again, you can find them on there, and they have all the recommended MPC modules that you should do. But they, like my clinical school, for example, scheduled them into our timetable, so it was a little bit easier for me to find time to do it. But not every clinical school did that, and no one like told us about it. So that's why I mentioned it in here, because I think they're really, really useful, and they run through very common things like how to prevent a venous thromboembolism, and they'll talk about prescribing warfarin, prescribing heparin, that sort of stuff. Yeah, so it's a really good way to learn about pharmacology, but once again, it's not really the focus of the year as much.
Sorry, Karim, is that on Canvas that they can maybe have a look at now, because the subject guide isn't complete yet?
I'm not sure. The subject guide you can definitely find on MD Connect, because I was actually looking at it, but I don't know if it's the updated one.
No, it's not the updated one.
Yeah.
At the moment, yeah. Just suss out Canvas, because they may have put those modules on Canvas with the whole prettying up Canvas project that they've got going on.
Yeah. And they're trying to make Canvas look good. So yeah, explore Canvas, explore MD Connect. Like you want to be able to use both. But that's it in terms of content that you actually need to learn for the year. There's quite a lot. Yeah, I'll pass on to Gabby.
Okay, so let's talk about learning in the clinical environment. For me, I think this was the most overwhelming part of MD2, especially because we were online for the entirety of MD1 and then just got chucked in a hospital with patients that have legs. They're not just like a screen. They're there with you 3D in person. So it was really scary. So that's one of the reasons why clinical learning can be hard, because of the patients. They're complex. They don't present like they say they will in textbooks, or like Amboss says they will. And also bedside teaching can be hit and miss. Sometimes consultants, regs, interns, they're really passionate about teaching, really great at explaining concepts, and great at explaining concepts to your level as well, because sometimes consultants will expect you to have a reg level of understanding of a topic, but you don't, because you're an MD2. So that can be really hard, but also it can be hard sometimes because you might feel uncomfortable. There might be some ethically questionable encounters that happen at the bedside with the patient there. For example, the patient being spoken about and not to right in front of them, which as a medical student, I think is really hard, because often the patient looks at you for support because either you've already spent time with them, or you're just the person on the outside of the circle who's just sort of hanging about. So they look to relate to you. So I found that to be really challenging, and I still do. And you've just got to find your own ways of dealing with that, whether it be to come back to talk to the patient later, or to talk to them in that moment, whatever it may be. Obviously, each circumstance is different, but just be aware of that there may be encounters like that. Also, the other thing about clinical learning is that procedural and clinical experiences are really scary. Doing your first clinical exam on a real patient who doesn't know the steps of the exam like your colleagues do, or doing like an IM injection or a venipuncture or a cannula or a catheter on a patient. That stuff is really scary. And if your hands aren't shaking and you aren't sweating on your first procedure, I'm surprised. I shook so much, my legs were shaking that I couldn't stand up, and the patient asked me if I was okay for the first venipuncture. But now I do lots of venipunctures and I don't shake and I feel fine. So it's just about overcoming that really scary part and overwhelming part of clinical learning as soon as you can, so that then you can jump into opportunities early, and you don't miss out on too much, because you're scared of failure and hurting a patient and wasting their time as well.
Definitely, yeah. I have definitely messed up some procedures, and it's mortifying, and you just feel so sorry, and you're like, oh my god, I'm so sorry. Yeah, you feel quite embarrassed, but you just got to give it a go, because we're all learning.
Exactly.
We had a really good question about the pathology and radiology lectures, whether or not they're categorized by rotation on MD Connect or on Canvas. Unfortunately, they're not. So the radiology lectures go in a very well-organized order, I would say. They kind of walk you through the different types of radiology, whether that be ultrasound, MRI, CT, X-ray, etc. And then they go through, all right, chest imaging 1, 2, and 3, and they go through cases. And then they'll do abdominal imaging 1, 2, and 3, and then there's cases and all of those. So it's really well organized, but it is in a specific order. And it's about 1 a week is how many you need to watch. For path, they're in a very random order, because it's each path lecture is specific to a specific condition. So what I mentioned, prostate cancer earlier. So there'll be 1 path lecture about that. I recommend watching 1 path lecture every 2 or 3 weeks, roughly. And that will get you through all of them. But yeah, good question.
Yeah. So the path lectures are ordered for more block type learning, whereas the radiology is body parts. So yeah, might be a bit of a random order. But in terms of other things that are hard about clinical learning is FOMO, clinical FOMO. Even Krim and I had it, because obviously him being at the Austin and me being at Shepparton, very different experiences. I had a very small clinical group, not a heap of students at the hospital that I had to fight for opportunities with. But then also I didn't have as many surgeries happening, and I didn't have as many patients to see and beds at the hospital. So there was a lot of things that Karim saw that I didn't see, and that I did that Karim didn't do. And that's totally fine. And that's the best part about having friends across different sites. You can talk to them about their experiences and learn from them. Try not to have this FOMO and jealousy of, I wish that I could go to a neurosurgery, because it's not helpful. And at the end of the day, every site has everything you need to complete the curriculum of MD2. And that's all you are after this year, is just completing the curriculum, and obviously learning the basics so that you can be a safe intern when that time comes. And all of the sites will provide that. And if you fear that they're not, definitely say something, but to your sub-dean or your dean, if you feel necessary. But all sites have different opportunities, different rotations. So try not to stress about that. As well as you might have to fight for opportunities sometimes, like you can't find cannulas or venipunctures. Definitely wasn't like that in SHEP. There was lots to go around. But I think that's maybe quite a big thing at metro sites. So that's why it's really good to get over that fear if you have the fear of doing those clinical and procedural skills early, so that then you can jump in and just chip away at them throughout the year. You know, you have to get like 3 ticked off of each, I think, but just try to do as many as you can. And the last thing we'll touch on is big days at the hospital. So MD2 can be quite time poor. You can be at the hospital for a lot. It like depends on the rotations. So if you're on surge, you may have to go in really early. And then there might be a surgery in the afternoon, so you end up staying all day. If you're in med, you might go to ward rounds in the morning and then end up staying for teaching, seeing a patient, and then you're there all day as well. You know, so it can be really long days. So I highly recommend planning for this. But then also just being aware as well when signing up to extracurricular activities and things like that. Okay. What's the night shift situation like for ED rotation? Good question. This is different at every hospital. In Shepparton, we got like assigned ED shifts, but then we could go in any other time as well. Because we were such a small group, there was only 8 people assigned to the ED at once. We would just talk to each other and say, hey, I want to go in tonight. Does someone want to come with me? And because of COVID, it was like max 2 students at one time. So you just buddy up and go with them. But you definitely didn't have to do a night shift. It wasn't a requirement or anything like that. But a lot of students did go in at least once in the evening or on a weekend just to see what the difference was like. Karim, what was it like at the Austin?
Yeah, very similar. We were scheduled on to one night shift maybe every fortnight. And it was the same thing, like go if you feel like you're going to get something out of it, but you don't necessarily have to go. And like that's the thing I'm talking about with some placements at some clinical schools, they 100% expect you to be there every time. And it's luck of the draw. Other clinical schools, they're very relaxed about it. Yeah.
Yeah, exactly. Okay, so now why can clinical placement be awesome? Because going back to our first point of why it can be hard, why it can be awesome, patience. Because all of your theoretical learning is now presented in the form of a human being, which makes it so much more memorable. And for me, it just makes me understand things so much easier because you talk to the patient, ask them about their symptoms, ask them about how they got diagnosed, ask them about their disease progression and how their condition actually impacts their life. And it's just much better learning experience, I think. Also, you get used to the hospital environment, get to do cool stuff like venipunctures and cannulas and catheters if you think that's cool. You get to meet doctors and see them in action as well, which can actually sort of be a bit depressing sometimes because you're like, is that what my life is going to be like? But then sometimes you're like, this is cool. This is the job for me. So it's definitely a pro. And there's also massive variation in your experience day to day. So you get out of that monotony of first year of just sitting down, doing lectures, doing tutes, and you get to do something different every day. You get exposed to lots of different things, get to see a lot of different patients. So learning becomes really exciting. So it's really easy to engage. And then you're also building on your professional practice as well, outside of PP, but also in the hospital environment, learning about how to, interact with different team members, interact with patients. You will make mistakes. You will feel like a fool a lot, but that's the whole point of being a medical student. Get to do the practical things that we've spoken about, and it's refreshing being on placement instead of stuck in your house.
Just a quick note on that. There's a good question about if you hear a code blue, what should you do? And if you'd like to attend a resus. If you hear a code blue and you happen to be nearby, I would observe. Okay, so if you happen to be at the code blue, you need to be the first responder, and you'll get teaching about that, but it's very unlikely you will be. If you happen to hear a code blue is in a specific ward and you'd like to attend, you can just go, stay out of people's way because they obviously have a very important job, and you can just observe. And if you get asked to leave, don't take it personally. It's just because they're trying to do their job. So it's about code blues, but they're actually pretty rare in the hospital, like in terms of being around when there is one happening. If you want to attend a resus, depends on the ED that you're in, and how the doctors feel about that. But for example, I would just the doctors will already be in there. I'll just go up, introduce myself. Hello, my name's Krim. I'm an MD2. Is it okay if I just observe for this particular patient? Almost like 9 times out of 10, they'll be happy for you to observe or even help out. Like, if there's something that's more simple to do, they're more than happy to help.
Exactly. And you'll get all teaching and advice from your clinical schools about this. But yeah, if you want to get involved, but just beware that obviously the patient comes first over your learning in that situation. Okay, in terms of learning at the hospital, our advice. So at the hospital, when you're going around seeing patients, talking to doctors, talking to nurses, write a list of concepts down that you want to revise later. If a doctor says something or asks you a question about something and you don't know what it is, write it down. Keep a little book on you if you can, like a little notebook that can fit in your scrubs or your pants pocket. I think is really great so that you can look back at it throughout the year, but also so you can go home and be like, right, there was 5 things that I didn't know today. Let me spend an hour searching these. And it just makes...
Sorry, Gab, really quickly. I highly recommend getting one of these. It's like a clear, this is like the interns folder. I don't know what to call it, but it's like a clear clipboard, and you can put stuff inside it. Like you'll see people carrying them all around the hospital. It's got a little pad here for your pen to go in. Highly recommend getting one. It'll just make your life so easy. Like I've started off with like a tiny little notebook and I've like try to write down patient histories in it. It's like impossible. You need like a big piece of paper to like scribble down things.
True. Yeah.
Okay, sorry for interrupting. Please.
No, that's okay. Those nerd boxes, that's what I like to call them, work really well in Gen Med and Surge as well. If you're not in theatre, obviously, don't take that into theatre. But on ED, I preferred a little notebook because like I was in my scrubs and was running around and doing lots of things, but also you can fit a snack in those boxes as well. So definitely take a muesli bar in there if you like. The other thing is if you're attending clinics, do a little bit of pre-reading. You obviously won't have a list of things, but for example, we had one neuro clinic in Shepparton because the neurologist rotates and only comes 1 day a month. So I just like quickly looked up things like stroke, MS, Parkinson's. I think that's probably it. Just quickly look them up so that then if I saw any patients with those conditions that day, that I could have some background knowledge about it and hopefully, get a more effective learning experience. And that ties into the next tip of be curious. Ask yourself questions, ask patients questions, ask doctors questions. Both patients and doctors appreciate students asking questions because it shows you're engaged and it shows you care. So don't be afraid to do that. Also, make sure you're reflecting on your learning and your understanding. We said it to the MD1s to you guys last year. It's really important to constantly be reflecting on your learning, both in the hospital and outside of the hospital, to make sure that you are understanding what you're learning. You don't want to get to the end of the year and realize that your learning methods didn't work. So just constantly check in on yourself and try to figure out what your learning style is early if you can. Just trial a few different things, get advice from people, because we don't want you cramming at the end of the year because these exams aren't crammable, I would say. They're very much testing your understanding rather than your ability to memorize things. So when you see a presentation, try to look it up straight afterwards or that night, as you're more likely to recall it next time. And that's the importance of that book on placement, or like Karim said, the nerd box, because it allows you to write those things down, but it can be really easy to write down like 50 things at the hospital because you don't know what anything is. But just try to write down the big picture things. If a consultant talks about some random drug that they're doing this trial or this research on, don't worry about that. But if they ask you a question on heart failure and you can't answer it, then look up heart failure that night. It's about being aware of what's important and what's not. And that ties into the last thing. We're all about big picture learning. Same as last year that you were doing in MD1, we're carrying that over to MD2, and it matters even more now because the things that you're learning in books are presented in front of you as people. So it's really important to keep that in mind, that not everything that's written in the textbook presents like that in real life, and that there are people behind, you know, patient bed 11 or whatever, or the person with a diabetic foot ulcer. There are people behind those conditions, so it's really important to keep that in mind. Some other things, it's really important to be organized and to stay organized throughout the year. So have a schedule, know when you're going to have to be in the hospital, when you've got your placement time. Each block's going to be a little bit different, and each hospital will obviously be a bit different. So you might have to have a different schedule for each block, but definitely block out your placement time and block out your study time. So aim to find enough placement time to see the conditions, but not so much that you don't have enough time to learn the conditions outside of the hospital. So you need to solidify your learning in the hospital with the content at home, with the lectures and that extra research you're doing in textbooks or through Google. And you obviously need time for assessments. Don't leave these to the last minute. You'll have clinical assessments like mini CEXs, long cases and things like that, which Karim will go through. Do them as early as you possibly can, so that then when it comes to exam time at the end of the year, you don't have to worry about the other things as well. And if you can, don't stick around if you're not benefiting. So if you're in the hospital and not much is happening, you've been rejected by a few patients, doctors are really busy, just go home, do something else that's more worth your while, and try again tomorrow. Don't be afraid of that. I felt really guilty in the beginning, and I was just staying at the hospital and just like swinging on a chair because there was nothing to do. Just know when to go home, and you can come back later. And that ties into find time to relax, especially if you're at the rural sites. There's lots of fun things to do, lots of people that you're living with. Explore the area, especially if you're only going to be there for a year. Really make sure that you do have a solid chunk of time each week dedicated to you and relaxing. So let's talk about the thing that's not relaxing, exams. Karim will talk about this, but I will just jump in. I'm aware you guys are using Kaizen this year, I believe. We're new to Kaizen as well. So it used to be just an MD3 and 4 thing, but now they're introducing it for everyone. So we can't give you much advice on that because we haven't used it before. But I would just say ask some MD4s if you can find some for advice on that. And the biggest advice that we've been given is just make sure that you get the consultant to assess you right then and there. Don't leave it to send to email, because otherwise they'll never get round to it. So hopefully that helps. But Karim, did you want to talk about assessments?
Yep. We'll try to make this brief, but I think you guys will really appreciate this stuff because it really helps to lay it all out in this sort of format. So you've got a few written and a few practical assessments. So your written ones will be CAP 5 and 6, the progress test, short answer questions. Practical ones will be procedural skill hurdles, mini CEXs, which are histories and clinical exams, long case, and OSCEs. Next. Okay, so breaking these down, you guys will be familiar with the CAPs, the MCQ questions, based tests. In MD2, they are very different to MD1. MD1, they're very much fact-based, you know, like, do you know this niche little fact? And then MD2, they are like extremely clinical based. So, you know, you're presented with a clinical scenario and you have to make a decision based on that for what you think the correct answer is. The progress test is similar. It's an MCQ. It's very hard. It's MD4 level knowledge. Most people or many people don't pass, but it's a hurdle with no pass marks. So you just have to show up and do it essentially. The short answer questions was probably the hardest exam we had last year. Gabby, would you agree? At least I found it the hardest. So it's 5 or so questions, all short answer with multiple sub questions. But I'll break these down early for you guys because I didn't know any of this until like a month before the exam. Essentially, the way that the exam is organized is it's common presentations. So shortness of breath, chest pain, abdominal pain, like things you guys will be very familiar with. the way the question is presented is essentially you're given a clinical snippet. So they'll describe a clinical situation. Then your questions will be based on the history, examination, investigation, and basic management around that presentation. So like as an example, Tim comes in with chest pain. What history questions would you like to ask? What common examination findings and related to what conditions would you expect? So if they had, let's say, like if they had what am I thinking of here? Like some sort of PE or something, you might look for a DVT, calf swelling, and soreness in the calf, something like that. Investigations like, okay, I'd order troponins, I'd order a chest x-ray, I'd order an ECG. What basic managements? Okay, like I've come up with a diagnosis. What is the basic management of that diagnosis? It's very much based on that. And that's why it's so important to know your presentation and key differentials for those things. And the way I'd recommend practicing for that is writing out your differentials. What are the important history questions you have to ask? What are common exam findings for each differential? And what are some important investigations for each presentation? And then management, just try and touch on like the really important stuff. So like obviously if someone has a PE, like you'd want to anticoagulate them, for example. If someone's had, a full-on STEMI, you need to send them to the cath lab to get that sorted out. So just think about that sort of stuff, and you guys will learn more of this throughout the year. Okay, and then some of the other ones. So procedural skills hurdles, very simple. Like you'll just have to do some venipunctions and cannulas throughout the year. Mini CXs, so these are histories and clinical exams. You'll be assessed by a registrar or consultant. They'll watch you take a history or do a clinical exam on a patient. The long case, this is done very differently at each hospital. But my experience was we had 3 throughout the year. We got tutorials on them all throughout the year, so you guys will learn a lot more about these. But essentially, it's like a 1-hour history from a patient. So that's history and examination, hopefully. If you guys get to do in person, we did it online, so it was only history. And a 15-minute presentation about that patient, which sounds terrifying now. And I was certainly terrified at the start of MD2 about the long case. But it's actually probably the best, I would say, assessment of your actual skills as a medical student and an up-and-coming doctor. And in OSCEs, you guys will be familiar with, so you get these 2 times a year, and it's based on your rotations. It'll be 1 history and 1 exam. Okay, probably take a screenshot of this slide. It's really useful. So these are the common OSCE topics. Some of them will look really random at the moment, like neck lump, altered consciousness state, that sort of stuff. You guys probably won't have come across them, but you'll start learning about these presentations more throughout the year, and you'll start coming up with your differentials for all of them. And finally, some long case advice. The best long cases, and you'll hear this again and again, but they are common things. So like COPD, diabetes, kidney failure, liver patients, like just really, really common stuff. People with chronic health conditions. When you're first practicing long case, I really recommend going for the simple, easy patients first. So like they've come in with chest pain and they just have like a background of, hypertension and a few other maybe risk factors for heart disease, and that's it. And then move on to more and more complex patients later on, because at the end of the year, you'll get very, very complex patients. So at least that was my experience. And build your long case structure over the year and just practice it over and over again and constantly seek feedback for it. Any other bits of advice? Go.
I think like everyone does long cases slightly differently. So trial a few different methods in the first few weeks. I definitely did. There's the manila folder. I don't know if you guys have heard of it, but I don't really know what a manila folder is. Like I have them, but I don't know what they're used for. Filing things, I think, in a filing cabinet. But I used it, I just like folded it a certain way, and then I remembered like in my mind what each box was, like whether it was history of presenting complaint, drugs and allergies, or if it was social history. So then it prompted me to ask the next question in my long case, because in the final assessment, you can't bring any notes in or anything like that. So you need to be able to remember all of the questions to ask. So for me, that was a really good method, but other people just preferred pen and paper. Other people just stuck to the Socrates and expanded on it, sort of thing. So just like trial a few different methods and then figure out what works best for you. But yeah, I agree. Practice as much as you can. You don't have to do that many throughout the year. I think you have to do like 3 technically, but try to do like 1 a week if you can, especially when you're in Gen Med. That's the perfect time to get really good at long cases. Okay, some extra advice for assessments, Karim. Practice questions. We did have a question about this, if AMBOSS and PassMed were question banks. So PassMed is a huge question bank. There are a lot, and you can choose whether you're in like the first 3 years of medicine or the final years. That's based on like an undergraduate year. So you guys would be in the first like medical student year 1 to 3 level. But Karim and I actually ended up doing final year student questions towards the end of the year, because the question style on PassMed was really close to what we got in our exams at the end of the year. So that is an extra fee on PassMed, but I think it worked out to be like 20 or 40 Australian dollars. And I used it every day, and I think so did Karim. And they were really high quality questions. So definitely recommend investing in that. AMBOSS as well does have practice questions and practice OSCEs. I didn't use them as much. I just used AMBOSS as more of like a textbook, because it has really good summaries of all the conditions. You can look up conditions on AMBOSS for free, but I think you get like 3 free articles a month or something. And after that, you have to pay. So you can do that to trial and see how you go.
Or you can try use incognito tab on Chrome. Apparently that's the hack way of doing it, but
we don't want to encourage illegal downloading of academic content.
Yeah, this is off the record.
Don't listen to that. Pay for the subscription, because people are putting a lot of time and effort into making those resources for us. In terms of practical advice, try to get feedback and advice often from as many people as you can, from your peers, from nurse educators, from doctors, whoever you can get your hands on. Practice exams with different people as well. As many people as you can get advice from and tips from, the better. And that ties into doing as many mini CEXs and long cases as you can under timed conditions is very important. And here's a big list of different apps and websites and resources that we found useful. Feel free to take a screenshot of this. We won't talk through all of them, but we've already spoken about AMBOSS and Pass Medicine as probably Karim and my most used resources, I would say.
Love them.
But also ETG is really good for drugs, and that's what all the doctors are using, especially in GP land. Not that you guys will be in GP land, but that is something that is definitely used. Another hack, Karim, did you want to show them your little pocket diary?
This is your Bible. This is really, really useful as a medical student. It's called the Oxford Handbook of Clinical Medicine. Highly recommend getting it. It's very good. It's very detailed, and it's incredibly concise and like everything you need to know about any condition.
Yeah, it's just a high yield summary of all the main conditions, and it's a perfect size to take on placement as well. So if you can get your hands on one of those, look on Facebook Marketplace and eBay and all of the other secondhand sites first, because a lot of people do sell them cheaper. But if not, I reckon it's worth buying it brand new as well. I've just bought one on Gumtree for $5. Yikes. That is so good. Does the addition of the Oxford Handbook matter, do you think, Karim?
I don't think so. Probably not. Like, what are they going to change? Like 3 words.
Yeah. And obviously, like, what you learn won't just be coming from that book. It'll be from other resources as well. So if like drugs or something like that are out of date, it doesn't really matter, because you'll either learn it elsewhere or you probably won't be tested on it, because we're not tested on management too much.
And can I just point out 2 really useful resources when you guys are practicing OSCEs? I use these a lot in mid and end of year. OSCE Bank, super useful. It's essentially just a bunch of different OSCEs that you can practice, and Clinical Prep, once again, just a bunch of different OSCEs you can practice. OSCE Bank is paid, Clinical Prep is a free app.
Also, we didn't put their Geeky Medics. They're really great for clinical exams specifically, but they also have practice OSCEs as well. So that's Geeky Medics. All right, does anyone have any questions at all before we move on to the last bits and pieces? Just wait a couple minutes because I understand people type questions. It takes a little while. But it looks like we're going to be finishing right on time, which is awesome. So thanks for coming to our first event, free logistics event this time around. But this is what our revision sessions will look like for MD2, because obviously they're a little bit different to our ones for MD1. So this time around, what we've decided to do is something that we wish we had last year and we didn't have. So we're going to give 2 revision sessions per block. So that's Foundations Part 1 and Part 2, Medicine Part 1 and Part 2, Ambulatory, Surgery, and so on. Actually, that's it. So there's the 4 blocks. So 2 revision sessions per block, which will probably be about an hour and a half. Same structure as last year. So really focused on high yield summaries of the core concepts. So we'll focus on your core presentations, on your core medicines and those conditions attached to those things, and present them in a clinical format, which really ties together that theoretical learning and that clinical learning. In a really easy way, because we're writing them for you. So it'll hopefully be a way that's really relevant to your exams, but also relevant to your actual time as a student doctor, so to speak. And we'll also have a mock exam at the end of the year, which we know you guys loved last year. So we'll produce one again this year for you guys. So how to get involved? We do have an early bird offer. So just like we did last year, all tickets to the events are $7.50 per event, but you do get 30% off if you're an Outlook Rural Health Club member. So if you're not a member, sign up and then use the promo code Outlook at checkout to get 30% off. So your ticket comes down from $7.50 to about $5. But if you get this early bird bundle now, you'll save even more money. And it comes down to $40 for all 8 sessions. So try to pay up front so that you can get it and get access to all record and live sessions. But this offer only lasts 1 week. So do get in nice and quick. Well, thank you all for coming. We'll see you at Foundations Part 1, which will be in a couple of weeks' time. Check out on the Facebook group chat as well as your emails for more information about that. Thanks, everyone.
Gabby, can I just ask a quick question?
Okay, after I stopped recording, we had a really good question by one of the students asking how Karim and I take notes for studying. So I just thought I'd include that recording here as well, just so that everyone who watches the recording from home can listen to that advice as well, because it isn't something that we touched on too much because everyone's note-taking technique is a bit different, but it might be useful for you. So have a listen if you like. Actually, Karim, did you want to explain how we did it? Because Karim, we worked together, but to be fair, Karim definitely picked up my slack. So you can describe the way that we did it. You're on mute, Karim.
Yeah, more than happy to describe it. So essentially, there's 2 different things you need to know for MD2, right? So you need to know core conditions. So like, once again, let's say we're talking about acute coronary syndrome. You need to know how it presents, what things you'd find on examination, what's the epidemiology, what's the risk factors, all that stuff. Plus, you need to know the core presentations. Okay, so if you got chest pain, what do you get from that? Like, what are the history questions? What are the examination findings for the various things, and so on and so forth. So the way we structured it is we kind of had this huge doc where we categorized things into different types. So for example, one might be cardiovascular. And then underneath that, there'll be core conditions and then core presentations. So I might as well show you an example.
Yeah, that's what I was just thinking. Maybe we just show. You keep talking through it. I'll grab it up.
I've got it.
Okay.
But yeah, essentially what it looks like is something like this. So let's say we're talking about respiratory. Sorry, this doc is super laggy because it's quite big. So they say you have something like someone presents with hemoptysis and shortness of breath, definition, the history of a complaint, like what examination findings, what investigations did you do, like what are your differential diagnoses. So that's what I'd do for the presentation. And then if I'm talking about a condition, so let's say we go through asthma. So like, what's the definition? What's the likely epidemiology it'll present in? What's the pathophys? Pathophys is like less important for MD1, but good to include in there anyway. Risk factors, clinical presentation, what investigations should you do? What's the diagnosis? What are some other differentials that present in a similar way? And then what are some key management concepts, complications, and prognosis? So you can see it's quite extensive, but like by making detailed notes, I found it really helpful in terms of consolidating that knowledge, because then our revision at the end of the year and just throughout the year, we'll be going through that doc and just going, okay, what age group does asthma present in? Like, what are the symptoms you like? And the most important part is what are the symptoms you'll get? What examination findings will you find? What are the investigations you should do? Like that is the most important, but it's good to have the other stuff as well.
Yeah, exactly. And so that's all of our lecture and tutorial content. So all of the like real hardcore curriculum stuff that's been set out. So core presentations, core drugs. And by splitting that workload between two people, it really makes it much more manageable without sort of missing out on anything either, because we still watched all the lectures. It's just if I jumped on there and I went to make a table about asthma and Krim had already made one, I just added extra stuff or read his lecture or read his table before I watched the lecture. So it's just really nice to divide the workload with another person if you can, or a couple other people. And it becomes, a really great study resource. But in terms of notes at the hospital, like Karim showed, that the nerd box is a great way to take notes. But when actually writing things down, I do recommend having like some sort of structure to your page. So in one corner of the page, I just had like questions or things to look up later. And then in the rest, I would sort of have like a running list of all of the conditions that I saw that day, or problems, like patient problems that they came in with. And then I would also practice writing notes like the interns do on ward rounds. So you can do like the SOAP method, which is subjective, objective, assessment, and plan. So that is a good way of writing notes at bedside. So I would practice writing a couple of those as well, but not too many because that was like really time consuming. Any other way that you took notes at the hospital, Karim?
Not so much notes. I was just going to say, like, in terms of your other learning as well, then like, writing down notes is all good and great, but you got to also like test yourself. So that's why like we really use a lot of past med to test our knowledge, because it's all good and well like writing this stuff down, but you got to make sure you actually somewhat know it. And then for short answer questions, like we would practice. I remember we made a huge doc as well that was just a list of presentations, and then we'd write down differentials, key history, key examination findings, and then for that presentation, key investigations.
So what we were doing in that, it was really trying to like preemptively think about what questions we would get on short answer test from the university, and test each other on that out loud as well as I tried to do past med questions for like 15 to 20 minutes per day, like I did with Anki in first year. So that's what we just got a question on. Anki's, great if you can make the cards for it. I personally don't have the time nor the energy to make the cards for it. If I did,
can I just really quickly say it's
Yeah.
also less useful for
Yeah.
MD2 because in MD1, like it was so good because you just needed to know facts. But for MD2, you need to really think about like the clinical situation. So I found it a lot less useful. But like by all means, like a lot of my friends ended up using it and they went really well. So just
I
up
think
to
it
you.
comes down to how you write your cards. If you're writing your cards with a real like clinical lens on, so you paint the picture of different patients coming in with different conditions, and they're not just like saying like define COPD or something like that. It's really like clinically focused cards. I think you can make it work because essentially that's the same thing as past med. You just don't get the spaced repetition or whatever. So yeah, I think you can make it work, but put a lot of time into making the cards good quality. And if you can't be bothered, just use a service like Past Medicine in place of it. Any other questions?
Good luck for the year. It's probably the best year in the degree.
For sure. For sure.